Very much, Michelle. Thank you, Barbara. Hi, everyone. My name's Lindsay Graham. I work at a charity called People First Independent Advocacy, and the charity I work for has been in fruition, I suppose, for 32 years this year. We're not a new charity. We are primarily based in Cumbria. However, we do work across the north of England. So we run projects in Lancashire, Cumbria and the North East, primarily in Teesside. Our organisation is all about supporting people to lead their best life. We're independent from statutory services, so we're independent from health and from social care. And we have a unique and privileged position, I suppose, to stand shoulder to shoulder with people and through some of their most difficult, challenging times and help them have their voices heard and their rights and choices respected. So I absolutely love the role I undertake at People First, and I think the organisation is brilliant. And I think what else is brilliant is there's People First, an organisation like ours, all over the country, all over the world, all working to support people to have their rights upheld. And I've got the pleasure of talking to you today about deprivation and liberty safeguards. And deprivation and liberty safeguards, I'm going to do it in the context that deprivation and liberty safeguards is the current legislation. That is the current legislation that we're all working towards. There is something in the future with regards to something called liberty protection safeguards, so LPS for short. That was actually supposed to be coming in April, 1st of April 2022, and before that, and it hasn't happened for lots of different reasons. But it's not coming yet. We don't have a time frame for when it is coming. So what we're doing is using the opportunity to make sure that people really understand the Mental Capacity Act, really understand their roles within the Mental Capacity Act, and also really understand the legislation as it is now, the deprivation liberty safeguards. So I do have a little bit of a presentation, but I promise it's not going to be death by PowerPoint, and I will be clicking off the slide, so we will be going on and coming back off. Okay, so I'm going to try and share my screen. If you have any questions at any point throughout the session, please do feel free to ask them if you pop them in the chat. And if it isn't the right time to answer them during the presentation, if we're going to go off on lose the flow, so to speak, we will. There is some time at the end as well for answering questions. So don't feel like you need to sit on something. Please do just ask. And Michelle's going to support and make sure we capture all the chat as well. So there's nothing to worry about there. Okay, so I'm going to share my screen. Okay, and we're going to go to this. Okay, so I can't see any hands now that might go up. Oh, sorry. There we go. I just wanted to just highlight that deprivation of liberty safeguards, there is a lot of jargon. Within most types of legislation, there are words that don't make things the easiest to follow. So I just pulled together a little bit of a jargon buster for some of the things we're going to be talking about today. So we're going to be talking about a supervisory body, and that's a local authority that is responsible for considering deprivation of liberty requests. So they are, for example, if the person is living in Newcastle, then the supervisory body there would be Newcastle. If the person was living in Cumbria but was funded through Newcastle, then the supervisory body would still be Newcastle. But they would probably work with Cumbria to make sure that deprivation of liberty requests are processed. So the managing authority, they're different to the supervisory body. The managing authority is the agency, the provider really of the care and the support. So that could be the hospital where the person's staying, it could be the care home, and it's their job to manage that person's deprivation of liberty. And we're going to touch on a little bit more about what some of those do. A relevant person, here's another bit of jargon for you. A relevant person is the person who may or is being deprived of their liberty. So they're the relevant person. and they have to have, by law, once they are the deprivation of liberty is authorised, which we're going to talk about later as well, they have to have a relevant person's representative, and that's somebody who's independent of the care home or hospital and independent of the health and social care services. And it can be a family member, it can be a relative, or it could be an advocate. The Court of Protection, that is a special court that is there to make welfare decisions for people who may lack the capacity to make the decision themselves. So if there's some disagreements between somebody's between, for example, the supervisory body and the managing authority, then they could utilise the Court of Protection, and so could the relevant person's representative. They could also utilise that court. Some more jargon. I've got another slide here. Litigation friend, that is if it was going to the Court of Protection and the person doesn't have capacity to litigate for themselves, then a person can be appointed to do that for them. A best interest assessor, that we're going to talk about that as well. That's separate to the best interest decision making process. We're going to talk about the best interest assessor role. Their role is to work out whether this deprivation of liberties is in somebody's best interest. We're going to click on and I'm going to talk about conditions. So when a deprivation of liberty is authorised, quite often conditions can be attached to the deprivation of liberty safeguard. So let's have a little bit of a think about actually deprivation of liberty safeguard, DOLS. What is that? What is a deprivation of liberty? Okay, so deprivation, it's a denial of something considered to be a necessity. We've got a liberty, which is the right or freedom to which all human beings are entitled and the government may not interfere. And then we've got safeguards. Safeguards, measures taken to protect someone or prevent something undesirable. So there's your definitions of deprivation, liberty and safeguard, and together they make up the DOLS. Okay, so the deprivation of liberty safeguard is an authorisation that says we recognise this person's being deprived of their liberty, and that deprivation is being authorised, and that's by the supervisory body. Okay, so that's by the local authority of where the person is based. I'm going to ask a question now. What do you think possible deprivations of somebody's liberty may be? If you're thinking about some of the settings where you work or where you've had work experience placements, perhaps a hospital setting, maybe a care home, what possible deprivations do you think people may come across where somebody's liberty is being deprived? I've got a long list, so don't worry if you can't think. So dementia would be a reason why somebody may lack capacity to consent to the care agreements, but it might be a reason why they may lack capacity to consent to the deprivation of liberty, but that just having dementia alone wouldn't mean that their liberty is being deprived. Being detained under the Mental Health Act, that is a framework, absolutely, that can detain someone of their liberty. So the Mental Health Act and the DOLS, they run alongside each other. Disorders of consciousness, again, that's more of a medical reason why somebody may lack capacity, which may result in them having a deprivation of liberty safeguard, but it wouldn't be a reason why that it wouldn't be a possible deprivation of their liberty. Okay, does anybody else want to have a think? Cognitive disabilities, again, that would be a reason why somebody may lack capacity. That would be classed as an impairment of their mind or brain, or a mental illness. And Donna, you've put being in a care home, and being in a care home could be, but we're going to unpick what is it about being in that care home that might be depriving somebody of their liberty. So, for example, I'm going to shoot off some examples here. Using covert medication. So giving somebody medication that they don't know they're taking and they can't consent to being given that medication, and then part of their care arrangements, it's decided that giving that person that medication is in their best interests, but actually it's being given in some yogurt and that person isn't being asked if they would they're not being informed or being asked whether they would like to take the medication. It's the decision's been made. They don't have capacity to consent to the being given that medication, and it's being given covertly. And yogurt is a common one. Okay, people are given medication in yogurt. So use of physical restraint to manage behaviour. Behaviours that appear challenging. So, for example, physical restraint may be somebody being held. It might be that they're being held in their best interest because of some of their behaviours and to keep themselves safe. However, being held like that is still a deprivation of their liberty because it's stopping their freedom. It's holding that person there. So that might be something that might be classed as a deprivation of liberty. Another thing is thinking about the care home, Donna, is locked doors. So, you know, you might have a care home or a hospital with a locked door, and the patients or the residents don't know the keypad, and they don't have the mental capacity to consent to being in the care home or the hospital. For example, restrictions on access to the community, and also, I don't know, bed rails, wheelchair straps and restraints in vehicles. They could all be things that would be withholding somebody and preventing somebody's liberty. So there is currently in the legislation, there is a test to think about, is somebody being deprived of their liberty? I'm going to go through that now, which means I'm going to share my screen again. Okay. And this is commonly known as the acid test. I don't know if people can see that okay without me having to do the slideshow. But if a person lacks capacity to consent to their care arrangements, and they're under continuous supervision and control, so somebody knows where they are continuously, they don't have independent control of their life, so that's around I don't know, when they have their meal times, where they are, where they sit, where they go, how they choose to spend their time, and also if they're not free to leave. So, for example, the keypads or locks on doors, maybe they're not able to leave, then that means a person could be being deprived of their liberty. And that is when care homes and hospitals, the managing authorities, must make an application to the supervisory body to say, we think we're depriving this person of their liberty and we need your authorisation to do so. We think this care and treatment is in this person's best interest, but again, they don't have the capacity to consent to that care and treatment, so we need the care authorised, and that's what the deprivation of liberty safeguard is. The dolls, it's a safeguard. Okay, so do we have any questions at this point about any of the things that I've talked about the jargon, the words? Because we're going to move on now to talk a little bit about the process of authorising a deprivation of liberty safeguard. And then we're going to look at some case examples as well to see, actually, are we depriving this person of their liberty or are we not depriving this person of their liberty? What do we think? And that's going to be interactive. So I hope you're all ready for that bit. Okay. Can I clarify age limits, please? Perfect. Yes, I can. So currently, the deprivation of liberties is for people aged 18 or over. Deprivations can be, there are different types of deprivation of liberty safeguard, and there are some changes in the legislation. So the LPS, the Liberty Protection Safeguard, that will come in the future will be for 16 years or older. But currently the deprivation of liberty safeguard is for 18 years older. It's for adults. Okay. So 3 ways to get a deprivation of liberty safeguard authorised. There is a standard authorisation, there is an urgent authorisation, and then there is a court of protection authorisation. Okay. me just share my screen a little bit because I'm gonna I've got some information for you to read while I'm talking. There we go. So again, we've got the key bodies in DOLS are the managing authority and the supervisory bodies. So it's the managing authority's responsibility to deliver the care and support. So it's their responsibility to recognise whether that care and support is depriving somebody of their liberty. And then it's the supervisory body's role to authorise that deprivation and also oversee it. So here we've got there's two types of ordinary authorisation. So we've got the standard authorisation and the urgent authorisation. The third type is a newer type of authorisation which came in after the legislation was written through case law, and that is through the Court of Protection. So that is where somebody may not be in a care home or hospital, but the level of care still amounts to a deprivation of liberty, and that would be through the Court of Protection that would need to be authorised directly rather than through the supervisory body. Okay, so roles and responsibilities. I think I've touched on this. The managing authority, it's their role to identify where somebody's being deprived of their liberty and then request in writing to the supervisory body to ask them to undertake some assessments to see if the person is being detained, deprived of their liberty, and the managing authority can also grant themselves the urgent authorisation. So if they recognise that actually I need to deprive this person of their liberty now to keep them safe, I can grant myself 7 days worth of an urgent authorisation, but they must put in a standard authorisation application at the same time. Supervisory body, it's their role to consider the request for the authorisations, it's their role to commission required assessments, and if all the assessments agree, then they must authorise the DOL. And they're also responsible for appointing, I've put IMCA there, but actually it's the relevant person's representative. So once a DOL is authorised, remember the person who's being deprived of their DOL, the relevant person, all of a sudden they've got a right to an independent representative, which could be a family member or a friend, or it could be an advocate. And the supervisory body is responsible for appointing that person. So urgent authorisations, the managing authority can grant itself the urgent authorisation, but they must also submit a request for a standard authorisation. Okay, and there are some specific timescales here, but currently because DOLS is under so much pressure, and it has been since about 2014, these timescales, although they are legislative timescales, they're not always met, and the CQC will want evidence of managing authorities having communication with the supervisory bodies about these timescales, and you'll see there's more timescales as well further through, which again is very challenging for supervisory bodies to meet. So standard authorisations, the supervisory bodies receive the request, they must inform the person themselves and people involved in their lives. So they must inform, I don't know, maybe a husband or a wife or the next of kin. And then there are 6 assessments which form part of the DOLS process. Some of these are really simple quick assessments. So one might be about the person's age, are they over 18? And that is basically looking at the form and checking, yes, they are. And that's one of the assessments done. Some of the assessments are a little bit more complex. So one of the assessments is a capacity assessment. Does the person actually lack capacity to consent to their care arrangements? And one of the assessments is a best interest assessment, and that's undertaken by a best interest assessor, which is looking at the person's best interest in relation to the care and treatment that is being provided that is depriving that person of their liberty. So once the DOLS is authorised, the supervisory body can attach conditions, and they are conditions are things that the supervisory body says, in order for you to be able to deprive this person of their liberty, then you must do this. So, for example, if in the DOLS it talks about covert medication, a supervisory body might attach a condition that says, okay, we're going to put, yes, you can deprive the person of their liberty by giving them covert medication, but actually within 6 months we want that medication reviewed. It might be that yes, we're going to consent to the use of bed rails to deprive the person of their liberty, but actually within 12 months we want the occupational therapist, a referral to be made to an occupational therapist to see if there are any other least restrictive options on that person's liberty. So those are the types of conditions. More and more we're noticing that conditions attached are about supporting people to get out in the community, and I don't know whether that's about a legacy from COVID, or whether that is more best interest assessors being more proactive around actually what does a good quality of life look like for people, and recognising that when people do go into care homes and hospitals, quite regularly the people don't always get out in the community as much as they perhaps previously did prior to moving to those types of care establishments. Okay, so there's a list of the assessments. I'm not going to go through them because it's quite complicated, each one, but if you do have any questions, I'm more than happy to answer them, and also I can point you to some further reading. So what we're going to do now is we're going to look at some case examples, and what I want you to do is think about, do you think this person is being deprived of their liberty? If they are, why do we think they're being deprived of liberty? And if not, why not? Okay, so keep those 3 things in your minds when we go through there's 4 examples. And these, obviously the names have been changed and identifying factors, but these are actual real experience that advocates have come across. Okay. So is the person deprived of their liberty? If they are, why are they? And if not, why not? And this is the interactive bit. So I'm hoping that we'll be able to have a little bit of a conversation. Okay, so we're going to talk about Betty first of all. Can everybody see that okay? Let me just see if I can move that up. Yeah. So Betty, yeah. She's been in hospital for 2 months following a hip replacement operation. She's recovered well and she's waiting for a return to a home in the community. The social worker has assessed Betty as lacking the mental capacity to consent to a living arrangement and is waiting a best interest meeting to decide on her long-term living arrangement. So there's some questions there about, is Betty going to be safe, and are her care needs going to be met when she goes home, or are other types of accommodation needing to be looked at? Okay, so this is going to take another several weeks for that to be explored. And one reason for this is a social worker has assessed her home in the community as currently inhabitable. So maybe Betty's got a history of hoarding, or maybe it's not in a safe condition, derelict perhaps. Betty is ready for discharge and she'd like to go home today. The ward unit is on a keypad, and Betty does not have the code to get out of the ward, and she also has bed rails on her bed to reduce her risk of falling out. So she's in hospital, she doesn't have capacity to consent to a care arrangement, and she's going to be there for another several weeks while her discharge is being explored. Do we think Betty is being deprived of her liberty? Yes or no? Does anybody like to come in and share their feelings? Yes, keypad and rails, that's gone in the chat. Anybody else?
Even though she may not have capacity, I think we still need to explore, isn't it, in terms of like what her wishes are.
Absolutely. Yeah, but given that she would only be able to be eligible for a deprivation of liberty safeguard if she didn't have capacity. So that's a practice dilemma. If Betty did have capacity and she wasn't consenting to a care arrangement, then would she be being kept there against her will without any legislative framework in place? And that does happen. That is really common, and obviously it isn't okay. There was did you just put in the chat? Sorry. No least restrictive option explored meanwhile until home is ready. Absolutely. And you would hope that would be explored during the best interest process. But at the minute, here and now, you're right, Betty is being deprived of her liberty, and that would need to be authorised through the supervisory body, and that would be the local authority of where the hospital is. So if Betty's in hospital in Gateshead, then it would be the Gateshead local authority that would need to be authorising that. And each hospital will have their own processes with regards to their own, I suppose, hierarchical different teams, whether it be the safeguarding team, whether it be a specific mental capacity team that would process the forms and submit them. But actually, staff on the ground, it's really important that we recognise when and if somebody is being deprived of their liberty. So we're going to go on to the next person now. That Betty was a nice, easy one to start us off. I don't know if they're all going to be as easy as that one. So let's go. So this is Alf. We're going to learn a little bit about Alf. Let me see. Oh, sorry, it keeps doing that every time I try and move. I'll just make. Oh, sorry, you're trying to read, and I'm going to give you all a headache. Okay, so Alf is currently living in his own home in the community. He has 2 dogs and a cat. He's lived in the same home for the past 30 years. His wife also lived there before she sadly passed away. Alf is becoming lonely and feels he needs a higher level of support and social inclusion. Alf's social worker visits and assesses his mental capacity. The social worker deems that Alf does have the mental capacity to consent to his living arrangements. Alf asks his social worker to move him to a residential home as he is desperately unhappy. The social worker feels that if Alf does not meet the eligibility criteria for residential care, she feels that he does not meet the eligibility criteria for residential care, so therefore will need to remain at his own home. Okay, so he's living in his own home. He's feeling lonely and isolated, and he's asked his social worker, can he go to the care home? She's assessed his capacity and thinks he does have capacity to consent to his living arrangements, and feels that actually he needs to remain at his own home. So what do we think about Alf? Do we think, is Alf being deprived of his liberty?
I've got 2 answers in the chat box so far. One says yes and one says no.
Helpful. Okay, yeah. Oh no, the I don't know if Alf relates to the Lauren. Does your comment relate to Betty or Alf?
Betty, sorry.
Yeah, that's fine. That's fine. Yeah, so Christine says no, Alf has capacity to decide and may seek alternative options. Brilliant. So he has the capacity and he's able to seek some alternative options. He might need some support to do that. He might need some support from the social worker to help him explore his own options. There's also things around finances. Could he afford to pay for his, his own residential care and move there independently? There are lots of people who do that, who perhaps don't need the level of care just yet, but who plan for the future. So you are absolutely right. He is not being deprived of his liberty. If he did lack capacity to consent to these care arrangements in his own home, that could be, and he was being deprived of his liberty, that could be authorised through the Court of Protection if it was deemed to be in his best interest. Okay, but as it stands right now, he isn't being deprived of his liberty. Let's go and meet Ali. Let's find Ali. Okay, there's a delay on this thing. Let's click it again. Okay, so Ali, he's 85 years old and he's been diagnosed with dementia. He's been in a residential home for about 4 years and has recently become very unsettled. Ali believes he has a farm where his wife and children live. However, the farm was sold some years ago and his wife is also in residential care. His children come to visit him on a regular basis. Ali is on a locked unit, is sometimes prescribed medication to reduce his anxieties, and only has access to the community when he is supported by a staff member. Ali has also had some difficulties with another male who lives on the unit with him, which has at times resulted in verbal altercations which upset Ali greatly. So he's got a diagnosis of dementia, he's been in residential care for 4 years and he's very unsettled. He's on a locked unit and is sometimes prescribed medication to reduce his anxieties. And it sounds like he's not getting on very well with another gentleman who also lives in that care home. Where are we? Let me find you. Okay, so Carla, I know your comment related to Alf. So let's think about Ali. Is Ali being deprived of his liberty? And okay, so we've got yes here. Deprivation of liberty, locked unit, unhappy with peer and medication, could be considered chemical restraint. Lauren says yes. Christine says yes, he is deprived. He meets the acid test. Donna's adding yes, locked unit. So the majority of people are saying yes. Any other people on the other side at all with a different view? No? Okay, so all that information could suggest that Ali is being deprived of his liberty. However, just because Ali has a diagnosis of dementia, that doesn't necessarily mean he lacks capacity. So the managing authority, the care home there, would need to undertake a capacity assessment to see actually does he have capacity to consent to his care arrangement? Does he have capacity to say yes, I'm happy to stay here, or actually I'm ready to move and I want to move now? Does he have capacity into the insight of an insight into the level of care and support that he might need? So that's a little bit of a trick one really, because it does indicate yes, quite possibly, but again, just a diagnosis of dementia alone doesn't mean that a person lacks capacity. And I think sometimes when we're working in fast-paced environments and we're having to make decisions really quickly, sometimes we are making assumptions about people's capacity without really fully exploring that. So we would need to really understand actually what is the level of his capacity before making that decision. Okay, so let's go to the next person, and this is our final case study. This is I'm just going to put my earphones in because there's going to be a little bit of traffic going through the room that I'm in. There we go. Can everybody still hear me okay? I hope so. Okay, so we're going to meet Ingrid now. Okay. So Ingrid, she's a 75-year-old lady who was a former teacher. Recently, Ingrid's health has declined and it was becoming more difficult for her to look after herself independently in her own home. The social worker visited Ingrid and completed a capacity assessment. It was established Ingrid does have capacity to decide where she resides. A residential placement was sought nearby and Ingrid was moved to a physically frail unit. The unit was a locked unit and Ingrid was under the continuous supervision of the staff members. Ingrid was very happy in her new residence and she settled quickly. Okay, so is Ingrid being deprived of her liberty? Let me just find it all again.
So is Ingrid allowed to come and go as she pleases?
So with Ingrid being on, let me just say, the information we've got is she's in a residential, she's in a physically frail unit. The unit was a locked unit and Ingrid was under continuous supervision of staff members and she's very happy in a new residence and settles quickly. It doesn't say whether she's free to come and go as she pleases, but you could assume from it being a locked unit that she might or she might not quite often when there's locked units, people aren't free to leave. Okay, so let's see what we've got. Where are we? 1304. Farouk, yes, possibly locked unit and unhappy with care arrangements and may lack capacity at times. No, as she has capacity. I don't think so. She has capacity to make the decision. No, she decided to move there. Ingrid does have capacity. She could decide with support to arrange to go out. Absolutely. So Ingrid isn't being deprived of her liberty because she did she does have the capacity to consent. I think you made a really important point there, Carla, about she decided to move there, and I think it's really important that sometimes when people make a decision to move to residential care, they do have the capacity to make that decision and to consent to the care arrangement. However, sometimes because of medical issues, maybe dementia increasing, and the person may then lose capacity. So it might be that when people arrive at residential care or in hospital, they have capacity. However, then they lose that capacity, and it could be vice versa as well. So in the session yesterday, that was looking at mental capacity, we looked at somebody who was admitted to hospital who didn't have capacity to consent to their care arrangements or their treatment options at the time of admission because they were unwell, really unwell. But then a week later, they were being treated like they still didn't have capacity, but actually they'd got better, and they wanted to make a decision to leave hospital, but they weren't actually being allowed to, because they were being told that actually they didn't have the capacity to make that decision. So it can work both ways. Let's just see. If she has capacity, then she's not being deprived. Absolutely. So does anybody have any questions about Ali, Alf, Ingrid, Betty that they would like to share that they've come across in some of their placements, work, education, training, and that they'd like to discuss before we move on to the next step? No, that's okay.
Lindsay, just with Alf, how frequently would you need to do that capacity assessment with somebody who's got dementia, who might have periods where they are more lucid and periods where they're not?
Yeah, so that would be, I suppose that would be a clinical judgment. There is no set time frames for how long people should there's nothing in the Mental Capacity Act which says you need to assess somebody's capacity every 6 months, because capacity is time and decision specific. So it's all about proportionality. So Principle 1 of the Mental Capacity Act is about assuming that that person has capacity. Principle 2, taking all practical steps to support that person to make the decision themselves. Principle 3 is around that person having the right to make unwise decisions. But then if all those 3 things are taken, then you wouldn't need to undertake the capacity assessment, and I would probably be looking at how often his care and support is being reviewed, and whether his needs are changing on a regular basis. What's his history? Has his feelings and wishes changed? Has he become more withdrawn from services? Any patterns in the behaviour that become more different? And also what he's saying. That might be something that maybe worth, but yeah, according to the legislation, there is no set time frame for reassessing somebody's capacity. I hope that answers the question. Okay.
Yes, thank you.
That's okay. So when somebody becomes a relevant person, when they're being deprived of their liberty, and I've got 4 minutes-ish left until we have an opportunity for more questions. When somebody has been being deprived of their liberty, then and they become the relevant person, that gives them some rights, and it also gives their representative rights as well. So the The role of the managing authority when the DOLS is authorised is to manage that DOLS. It is to respond to all the conditions. It is to make sure that the person's representative is keeping regular contact with them. It is to make sure that the care and treatment, if there are any changes, that's reported to the supervisory body. And the role of the relevant person's representative, in a bit more jargon, it's often called the RPR. The RPR can has access to non-means tested legal aid, so they don't have to pay for it, but they can get legal advice around the DOLS, and they can mount a challenge through the Court of Protection. So I don't know if Betty was being deprived of her liberty in the care home and she was objecting to her placement, she was desperately unhappy, she had a home in the community which she wanted to go to, or actually the representative felt like it perhaps wasn't in her best interest to be there, then the representative can ask the supervisory body to review the decision, and they could also they can also ask the Court of Protection. So they could make an application to the court with free legal support to review the decision. And there's two things that could be reviewed at the Court of Protection in relation to the DOLS, and the first one is the person's capacity. So does the person have the capacity or not have the capacity to consent to the care arrangements? And then the other one is actually, are those arrangements in the person's best interest? So an example of that is, I once worked with a lady who was being deprived of her liberty, and in my first meeting with her, she said, I've asked him, and she pointed to this this person who was doing some odd jobs around the care home. She said, I've asked him, how many people actually get out of here? How many people actually leave? He said, it's very, very few. He said, it's 30%. She said, well, I want to be in that 30%. I don't want to stay here. I want to go home. And so she was understanding where she was. She was retaining the conversation of that she'd had with this gentleman about her wanting to go and exploring ways of how she could leave, and you know, she'd weighed up the percentages, and she'd communicated she was very clearly objecting to her placement, but everybody around her was more than happy for her to stay there, so we applied to the court on behalf of that lady, with that lady being involved in that process quite heavily, to explore actually, what did she lack capacity? You know, did she really lack capacity? Because sometimes you can be so involved in situations that you do need that oversight, that you know, somebody removed from the situation, like a judge, to oversee and make the decision as well. And actually, it did turn out that she did lack capacity. By the time we got to court, there'd been some delays, and her level of dementia did increase, but we were still really, we then went on to look at whether the placement was in her best interest. If she was really didn't want to be there and she wanted to be in her own home, could the care be delivered in her own home? Again, it turned out it couldn't, and that was because of the property she had. It was a cottage in a rural village that was the level of adaptations that would have been needed to the property, to, for example, to move a boiler, to move piping, to readjust steps. It was disproportionate at the time it would take, and given her age and things. So the decision was taken actually for her to remain at home, but to be supported to go back and spend time in a garden. So there wasn't any pressure for her to lose a house or to sell a house. But she was supported to actually go home and spend some time in a garden, which was important to her. So people don't always get the outcome that they'd like through the court, but it's always important to remember that people still have that right. And there's some great resources out there that people can look at, and people can attend court sessions live as well. So we've got a question here. Does it depend on the setting? Let me just read that one. Let me click it open. Okay. We've got two questions here, sorry. I'm going to go to, I'll go to Carlisle first. If a carer would not get cigarettes for an 86-year-old John, is this deprivation of liberty? Okay, it could be a deprivation of liberty. So Farah, you've answered Carla's question, have you? Is that right? Does it depend on the setting? DOLS applies to hospitals and care settings mainly. If John is in the community, it may not be a deprivation of liberty, but it could be as well. So so it would absolutely depend on the setting straight away. Is he in a care home? Is he in a hospital? But even whatever settings he was in, why would a carer not get drink and cigarette? Is it something to do with that care agency's policies? That they wouldn't buy drink and cigarettes, and I would expect that to be case managed through a social worker, to undertake the best interest process around. If John didn't have capacity to purchase them himself, then I would expect it to go through a best interest process under the Mental Capacity Act. And the likelihood is that it would probably be in his best interest to have some drink and some cigarettes. I could imagine, although I do know of situations where best interest people facilitating best interest process can be quite risk averse, but that if that was a welfare decision that was taken that did get challenged later on through the court, that might not be looked on favourably, because a court is very much about supporting people to have take risks, and to take risks and be supported to manage those risks as well. So I'd probably need a little bit more information, but again, I'm happy to talk through individual cases, like anonymised at a later date. So quite often what we come across at the moment is when DOLS have expired. So at the moment, DOLS are authorised for up to 1 year. And what you tend to find is if somebody's quite settled and quite happy and they, maybe their needs haven't changed in a little while, then they will have a DOLS that's authorised for a year. But a DOLS can be authorised for anything up from a few weeks, a few days, and quite often, if somebody is objecting to their DOLS, to their placement, to their care arrangements, then they could be, then usually they're around 3 months authorisations, and that gives, I suppose, the representative enough time to make an application to the Court of Protection. Local authorities, supervisory bodies can make applications to the court themselves, but if I'm quite honest, they don't tend to do it as often as advocates do, as representatives. They tend to authorise the deprivation for a certain level of time, and then the advocate tends to do that. There are lots of different reasons for that. One of them could be around the funding. That for an advocate to access the Court of Protection as a representative, it's non-means tested legal aid, whereas that wouldn't be the case for local authorities. So that could be one of the reasons why, or it could just be a change in delivery, I suppose. But that is quite common that DOLS get authorised and then it's the advocates who make the applications. Okay. Can I say a bit more about what a best interest assessment consists of, please? Yes, I absolutely can. So the best interest assessment under the DOLS is around looking at is the care and treatment, what is the proportionality of the care and treatment, what are the person's feelings and wishes, what do people around that person say, and there's something called, I'm going to Google it now while I find it. I don't know if you ever come across any of the DOLS forms. I'm just on Google right now, so I can't see any nods. I'm going to control copy. I'm going to pop this in your in the chat. There we go. There's a link. So basically, there are some good practice. They're not legislative. They're not legislative forms. You don't. Local authorities and supervisory bodies don't have to use them, but they are good practice. So they're designed by ADAS. Okay, so what I'm going to do is I'm going to show you Form 3, and Form 3 is the best interest assessment form that there we go, that would be completed as part of, oh, I've done it again, sorry, as part of the best interest process. So who's the person, who's assessing, and then who else has been consulted with in relation to this this assessment, and then what records have I reviewed as part of this assessment. Then it follows on around the mental capacity. That's a different, some of these are different assessments. Okay, here we go. Matters that I've considered and taken into account. So this will take the best interest assessor through different aspects. It pulls together background information. What are the views and the feelings and the wishes? That includes past and present, historical views, cultural views and wishes of the relevant person. What are the views of other people? And then as a result of that, the best interest assessor will form an opinion whether the person's being deprived of their liberty, and they'll have to provide reasons for that. Then they also get the opportunity to think about actually what are the conditions and what are the recommendations. So are there any conditions that might be attached to this DOLS? Again, using medication as the easiest example, medication review, access to the communication, and then recommendations. A condition could also be that the person's allocated a social worker. Quite often now, the way different adult social care is run, people don't necessarily have a social worker. It might be that they're overdue a care and support review as well. So all those things could go into the DOLS. It might be around financial assessments, capacity assessments that need to be taking place. So all those different things could go in there, and that's what a best interest assessment entails. I don't know if that was helpful or not, but I've put the link there with all the other forms. I'm also going to put another link in the chat, which is, let me just find it, which is I'm just finding it now. Here we go. I don't know if anybody's come across Edge Training. Edge Training have some brilliant resources on DOLS and liberty protection safeguards, including basically a comparison table. What's DOLS now? What's LPS going to be? What are the differences? Brilliant, helpful resources. So I'll put that on there as well for you. Okay, so we've got 5 minutes left of our session. Does anybody have any other questions or any other things that they would like to explore in this very brief time frame? I appreciate it is a lot of information to take in. Like I said right at the beginning, DOLS is full of jargon. I don't think LPS is going to be much clearer, if I'm honest. I think it is also full of jargon. But I suppose by unpicking the different topics and the different words and really understanding them, that helps bust that jargon, I suppose.
Lindsay, just one question. Will it be okay for us to share the PowerPoint to all those who attended it? Yeah.
Yeah, absolutely. I can send that on.
Yeah, no, that was very interesting, like very in-depth and thorough from my point of view, because not having a vague understanding of deprivation of liberty safeguards and how you brought about those different scenarios has helped paint a picture. And knowing that when I am going to be in that situation to support somebody, I've got an idea of what routes to take and where to look for. So, and especially those links that you've put in the chat box have been absolutely great. And thank you so much, Lindsay, for that. Whilst I've still got your attention, I know we've only got about 4 minutes left. I'll just quickly share my screen with you to just promote some more of the sessions that we've got coming up. I'm not too sure if you're aware of them. So Tomorrow we've got a session with Autism Able, and we're going to have an expert by experience. She's going to talk about her difficulties understanding language, sensory issues, change in routine, and fear of hospitals. And I think, you know, as students and professionals who are on the call, it will give us that insight to see how we can best support those who are autistic when they do access our services. And then on Friday, we also got working and learning together as a team. So this is an organization called Sunderland People First that supported, they've actually been actively taking mental health and learning disability students on placement. So they're going to be talking about that experience and what worked well and how it could be improved. And they're also going to have voices from the self-advocates themselves who will talk about how important it is for universities to connect with them and what benefits they've had. So it's really, really interesting. And then on Thursday, which I've missed there, it's exploring what an independent advocate service is all about. That's going to be presented by Darlington Association of Disabilities. Correct me if I'm wrong there, Lindsay, and Lindsay's going to be supporting them as well in terms of that presentation. And I know that they'll be talking about, you know, the roles of self-advocates, why the organizations set up and how they are independent from a bit of summarizing a bit of what Lindsay touched on today and yesterday. So if you can sign up to Eventbrite and register for those next sessions, that'll be absolutely great. And last but not least, I'll stop sharing the screen. I am just going to put some questions from Mentee Minter in the chat box. So if you can kindly just quickly fill these in. They don't take more than 2 minutes of each, and it will be much appreciated if you can. So I'll be just dropping these in the chat box now.